First, we'll be discussing fluids and electrolytes. We're first looking at the distribution of fluid in our body, knowing that our cells live in a fluid environment and it requires electrolyte and acid-base concentrations to be maintained within a narrow range. Anything outside this range can cause life-threatening clinical manifestations. There are changes in our electrolyte concentration that affect the electrical activity of nerve and muscle cells, and they also can cause shifts of fluid from one compartment in our body to another. These fluid fluctuations can also then affect our blood volume and disrupt the cellular function of enzyme systems. It can cause cell injury. Disturbances in fluid and electrolyte, or even disturbances in acid-base balance, are common. And again, they can be life-threatening if we do not recognize whether these things are within the normal ranges, and which are very narrow. And we need to understand how these alterations occur and how our body is able to compensate and correct these disturbances when we see a pathophysiological condition. 2/3 of the body's water is intracellular, or ICF, and 1/3 of the body's water is extracellular, or ECF. So let's look and see what makes up the components of ICF and ECF. In the ICF, or intracellular fluid, there are small amounts of sodium and chloride and larger amounts of potassium. There is more phosphate and magnesium in the intracellular fluid than you would find in the extracellular fluid, the fluid inside the cells. Now, in the extracellular compartment, we have interstitial fluid and intravascular fluid, or our blood plasma. There are other ECF compartments that include the lymph and transcellular fluids, which you can see here. We have pleural fluids, synovial, peritoneal, pericardial, and even intraocular fluids. Any disturbance in this fluid and electrolyte or acid-base balance, again, can be life-threatening, so we need to monitor. Maintenance of these electroneutrality, or the maintenance of the electroneutrality between the ICF and the ECF, is important, because they are going to transmit electrical impulses. They also initiate the movement of water among the components. So what are we talking about when we say total body water? Well, this is the sum of fluids within all the compartments. This constitutes a total body water, or TBW. For instance, the volume of TBW is usually expressed as a percentage of body weight in kilograms, and the total volume of body water for, let's say, a 70-kilo person is about 42 liters. And then the rest of the body weight is composed of our fat-free solids, and particularly our bone mass. Although the amount of fluid within the various compartments is relatively consistent, there is an exchange of solutes, for example, salt and water, and this occurs between the compartments to help maintain the amount of body fat versus water and bone. It helps to maintain the unique composition. The percentage of total body water really varies on the amount of body fat and the age. And because fat is hydrophobic, or water repelling, very little water is contained in those adipose cells, or those fat cells. And individuals with more body fat then have proportionately less total body water, and they tend to be more susceptible to fluid shifts and imbalances, and this altogether can cause dehydration. In terms of aging and the distribution of body fluids, we know that the amount of total body water does change with age. For example, in a neonate, up to 80% of their body weight is water. As they move into childhood, it slowly will decrease to 60 to 65% of body water. And as they move into adolescence, the percentage of total body water really does approach the adult proportions, with the gender differences, of course. In males, there's a higher percentage of body water as a function of increasing muscle mass. And in females, there's actually higher body fat and less muscle due to functions of estrogen. And so, therefore, we have less body water as females. And you can see in this table the proportions. But why does the percentage of total body water decline with further aging? Well, there's several reasons. Increased amount of fat and decreased amount of muscle as we get older. There's reduced ability to regulate sodium and water in our body, which can shift that balance. Our kidneys over time become less efficient at conserving the sodium, and therefore we have difficulty concentrating it in the urine. There's also insensible water loss through our skin as it thins, and this may increase. And there is also that thirst perception that may be impaired as well. The normal reduction of TBW in an older adult really does become clinically important, especially when your body's under stress. Even little things like developing a fever or when they become dehydrated. That even little loss of body fluid at such times can be severe and even life-threatening. Think about which groups are at risk for fluid imbalance. In terms of the water movement between the ICF and the ECF, we have osmotic forces. Water moves freely by diffusion through the lipid bilayer cell membrane and through aquaporins, a family of water channel proteins, and this helps to provide the permeability in water. We also have osmolality. This is the number of osmoles of solute per kilogram of fluid. And the osmolality of total body water is normally at an equilibrium. We also know that sodium is responsible for the osmotic balance of our extracellular fluid space, and potassium maintains the osmotic balance of our ICF space. This osmotic force of intracellular fluid proteins and then the other non-diffusible substances balances out by active transport of ions out of cells. Water will cross the cell membranes freely so that the osmolality of the total body weight is really normally at an equilibrium. Normally, the ICF is not subject to rapid changes in osmolality. However, the ECF changes in osmolality. Water moves from one compartment to another until osmotic equilibrium is then reestablished. These points all move towards and point back to the term osmotic forces between the ICF and the ECF. Now let's look at the water movement between our plasma and the interstitial fluid. The distribution of water and the movement of nutrients and waste products between the plasma in the tissue capillaries and the interstitial spaces is a result in the hydrostatic pressure and the osmotic forces at the arterial and the venous ends of the capillaries. So, water, sodium, and glucose can move readily across the capillary membrane. The plasma proteins will help maintain the effective osmolality, or that concentration of solutes per kilogram, and they do not cross the capillary membrane, but they help to generate this plasma oncotic pressure. Albumin is really important. It's the primary plasma protein that allows for oncotic pressure. And it's because it has the highest concentration. Osmotic forces within the capillary are balanced by this hydrostatic pressure, which is primarily determined by our blood pressure and how much blood volume we have. Albumin in the vascular space will help to pull water in. The movement of fluid that's moving back and forth across the capillary wall is called net filtration, and it's best described by the Starling hypothesis, which we're going to see on the next slide. So, in addition to osmosis, which forces are involved in this water movement between our plasma and the interstitial spaces? So let's take a look at how water moves between plasma and the interstitial fluid through the forces of osmosis and hydrostatic pressure. And this is happening across the capillary membrane. So normally, the interstitial forces are negligible because only a very small percentage of plasma proteins can cross this capillary membrane, and the interstitial fluid moves into cells or then is drawn back into the plasma. The major forces for filtration are then within the capillary. So, as the plasma flows from the arterial to venous ends of the capillary, that force of hydrostatic pressure is going to facilitate the movement of water across the capillary membrane. So, oncotic pressure is going to remain constant because plasma proteins don't cross. Remember, the biggest plasma protein is albumin. And at the arterial end of the capillary, hydrostatic pressure is greater than the capillary oncotic pressure, and water filters into the interstitial space because of this. Now, because the oncotic forces and there's some water that moves back into the capillary, the net effect is that we're going to lose water from the capillary. This loss of water from the plasma will decrease the hydrostatic pressure within the capillary. Thus, at the venous end of the capillary, the oncotic pressure is going to exceed hydrostatic pressure. The fluids then are going to be attracted back into circulation, and this is the process that balances the movement of fluid between our plasma and the interstitial space. So the overall effect is filtration at the arterial end and reabsorption at the venous end. So filtration at the arterial end and then reabsorption at the venous end. Interstitial hydrostatic pressure is going to promote the movement of the interstitial fluid along with small amounts of proteins into the lymphatics or the lymphatic vessels. And then this is going to be returned to circulation. So what does Starling force tells us? It tells us that the net filtration is equal to the forces that are favoring the filtration minus the forces that are opposing the filtration. And so water is going to move between the plasma and the interstitial fluid by this osmosis and hydrostatic pressure. This is all happening across the capillary membrane, and this movement of net filtration is what is being described by Starling's law. Now we're going to talk about edema, which is an alteration in how water is moving in our body. With edema, which is excessive accumulation of fluid within the interstitial spaces, there's a problem of fluid distribution. It's not necessarily that there's fluid excess, but the way the fluid is distributed in our body could be the problem. There are sequestered amounts of fluid that can cause both edema, but can also cause intravascular dehydration because it's moving into the interstitial spaces. The pathophysiology is related to an increase in the forces that are favoring fluid filtration from the capillaries or the lymphatic channels in the tissues. So we have a disruption in Starling's law. Venous obstruction can cause hydrostatic pressure to increase behind the obstruction, pushing the fluid then from the capillaries back into the interstitial space. Venous blood clots, hepatic obstruction, right heart failure, tight clothing around our extremities, prolonged standing. These are all common causes of venous obstruction. Right congestive heart failure, renal failure, cirrhosis of the liver, these are conditions associated with excessive sodium and water retention. So in turn, we would have volume overload, increased venous pressure, and we would also have edema. The volume of this interstitial fluid is exceeding the capacity of what the lymphatics are able to return back into the vascular space. If we have decreased plasma onconic pressure, this is because we have a diminished production of plasma albumin. Decreased onconic attraction of fluid within the capillary is going to cause this fluid to move into the interstitial space, resulting in edema. Decreased synthesis of plasma protein and onconic pressure is going to occur with liver disease, if there's protein malnutrition, if there's losses in the plasma protein itself, and this can happen with nephrotic syndrome of the kidney. It can happen with hemorrhage or even serious drainage from open wounds or burns. Increased capillary permeability, number 3, is usually associated with inflammation in the immune system. These responses are often the result of some type of trauma or a burn or some type of injury, something crushing, or we have a neoplastic disease or allergic reaction or infection. Then we have the excess amounts of fluid that escape from the plasma to the interstitial space, and this is what is going to cause the edema. This type of edema is often very severe because the loss of proteins from the vascular space, and this is going to decrease then the capillary onconic pressure and increase the interstitial onconic pressure. With both of these processes happening together, we have a series of edema that can be very severe and could turn into fluid movement into the interstitial spaces. The last of the common mechanisms is lymphatic drainage. This occurs when lymphatic channels are blocked. And how do they become blocked? There could be an infection or a tumor. Proteins and fluids are not being reabsorbed and accumulate in this interstitial space. This is going to cause lymphedema. Lymphedema of our arms and our legs can occur after surgical removal of our axillary or our femoral lymph nodes. And usually this is happening when we treat for cancer. We're removing those infected lymph nodes. And that is why cancer patients that have the removal of axillary or femoral lymph nodes may exhibit lymphedema. There is protein and fluids that are not being reabsorbed, so they're going to accumulate in this interstitial space. Now, edema can be considered localized, meaning it's only in one area. It can also be generalized. So the fluid is spread out throughout dependent areas, or it can be termed third spaced, which means that the fluid is trapped and it's unavailable for any type of perfusion and any type of metabolic activity. Dehydration can develop as a result of this sequestering of fluid or this trapped fluid. And some of the reasons why we would have this trapped fluid has to do with someone that is severely burned, and large amounts of vascular fluid are lost into the interstitial spaces. And this is going to reduce our overall plasma volume. And if our plasma volume is reduced, our blood pressure is reduced, and this can cause shock. Now we're going to talk about sodium, chloride, and the effect on water balance. Now, the kidneys and hormones have a central role in maintaining our sodium and water balance, and we know that water follows the osmotic gradients to establish the changes in our salt concentration. So we're going to look briefly at sodium and chloride, and we're going to expand on this concept in further slides. So sodium regulation or water balance is regulated by our kidneys through renin, our adrenal glands through aldosterone secretion, and through the posterior pituitary through the ADH secretion, which is our antidiuretic hormone. But don't forget, the heart produces natriuretic peptides that also help to regulate sodium and is a antagonist to renin and aldosterone. Now, sodium accounts for 90% of our ECF cations, or the positively charged ions. And it's the most abundant ECF cation, and along with its constituent anions, or negatively charged ions, like chloride and bicarb, or bicarbonate, sodium is going to regulate the extracellular osmotic forces and therefore regulate water balance and our extracellular fluid. It's important in other body functions because it helps maintain neuromuscular irritability, like our nerve impulses, in conjunction with potassium and calcium. It helps to regulate our acid-base balance through sodium bicarbonate and sodium phosphate. And it participates in cellular chemical reactions and the transport of substances across the cellular membrane. Chloride is a major anion in the ECF, and it is what provides electroneutrality, particularly in relation to sodium. So they work together. The chloride transport is generally passive, and it follows the active transport of sodium. So wherever sodium goes, chloride is just passively following. And it increases or decreases based on or proportional to the changes in the sodium concentration. Chloride tends to vary inversely with changes in the concentration of bicarbonate, which is another major ECF ion. So wherever sodium moves, chloride moves, but also water moves. So looking at sodium first, the normal range is 135 to 145 milliequivalents per liter. The total sodium represents a balance in the ECF between the uptake across our digestive epithelium, and then also how it's being excreted in our urine and through our perspiration. If we adjust sodium even more than 10 points within a 24-hour time frame, this could lead to seizure. So it's really important to maintain and to correct in narrow ranges. Chloride, the normal range is 95 to 105 milliequivalents per liter. And again, remember, this transport is generally passive while sodium is active. And it's going to change inversely through concentrations of bicarbonate and also other major ECF anions. So it's not a major player, but it's definitely necessary to help with the sodium transport. Now we're going to bring sodium and water and the RAS system together. We know that aldosterone regulates our sodium and potassium balance, and it leads to the sodium and water reabsorption that occurs back into circulation, and then we excrete our potassium. So we're going to look first at renin. Renin stimulates the formation of angiotensin 1, which is an inactive polypeptide. Angiotensin converting enzyme in our pulmonary vessels will then convert angiotensin 1 to angiotensin 2. Angiotensin 2 causes vasoconstriction. This vasoconstriction, which we learned in the cardiac lecture, is going to elevate the systemic blood pressure, therefore stimulating the secretion of aldosterone. Vasoconstriction elevates our systemic blood pressure, but it also restores renal perfusion or blood flow to the kidneys. Aldosterone is going to promote sodium and water reabsorption by the proximal tubules of the kidneys. By doing this, it's conserving sodium. It's going to conserve blood volume and our blood pressure. Aldosterone also stimulates the secretion and therefore the excretion of potassium by the distal tubules of the kidneys as well. And this reduces the potassium concentration in the ECF. The restoration of the sodium levels, our blood volume, and our renal perfusion is going to inhibit further release of renin. So our body knows when there's too much salt or not enough salt, or too much pressure or not enough pressure, and it feeds back that loop to keep everything balanced. And you can see that here again in this schematic, where if we're looking at this top one, we know ADH is coming from the posterior pituitary or the brain. We have aldosterone that is derived from the adrenal cortex. All of this is being pushed into the kidneys, and the kidneys are going to have a reaction: increased sympathetic, decrease in our blood pressures, and decrease in our sodium delivery to the distal tubules. With this decrease, then, our renin is going to be activated, which then activates our angiotensin 1, ACE to angiotensin 2. This will reversely now increase our SVR, which is going to increase our arterial pressure. If we have an increase in blood volume and cardiac output, this is also going to increase our arterial pressure. And this can happen if ADH and aldosterone affect the kidneys. And again, you can see it here in this schematic as well. I want you to ask yourself and be able to verbalize what the factors are that stimulate the release of hormone aldosterone. Aldosterone is only going to be stimulated if we have not enough volume, not enough sodium, or we have too much potassium and we need to push it out, or if our sympathetic nervous system activates the RAS system. Let's look now at the antidiuretic hormone, which helps with water balance. Well, how does the secretion of antidiuretic hormone change the perception of thirst? We're going to take a look at that in just a minute, but first let's look at ADH, which is also called vasopressin. It's a powerful vasoconstrictor, and it's secreted by osmoreceptors in the anterior hypothalamus and then stored in the posterior pituitary gland. The hypothalamus is going to stimulate water conservation at the level of the kidneys, and it also stimulates the thirst center. So, factors that stimulate the release of ADH, like what would cause ADH to be let go? If there's hyperosmolality in the ECF, or if there's hypovolemia, if our body temp, our core temp gets too hot, and some medications like opioids and even oral hypoglycemics can cause the release of ADH. ADH is regulated by a feedback mechanism, and the restoration of plasma osmolality, blood volume, and blood pressure would inhibit ADH secretions. But with fluid loss or dehydration, we will have a decrease in blood volume and blood pressure. So the baroreceptors, or the baroreceptors, which are sensitive receptors that help with volume and pressure. Also, we have stretch receptors that are sensitive to arterial volume and pressure. Both of these are going to stimulate the release of ADH. When arterial and atrial pressure drop, these baroreceptors are going to signal the hypothalamus, and it's going to release ADH. The reabsorption of water mediated by the renal response to ADH is going to promote the restoration of plasma volume and then thus also our blood pressure. When there's higher concentrations of ADH, it's going to stimulate peripheral arterial vasoconstriction. So here it is, a powerful vasoconstrictor. And then it's going to increase our arterial blood pressure. Now we're going to move back into the natriuretic peptides and think about how they contribute to the movement of water. Well, ANP and BNP, these are cardiac muscle markers, and they're released by the cardiac muscle cells. When there's an increase in transmural arterial pressure, transmural meaning going through the whole artery, and it's caused by increased intra-arterial volume, and this can happen particularly with heart failure. So therefore, this is why ANP and BNP are important markers to look for with heart failure. Well, ANP and BNP is going to increase our sodium and water excretion to the kidneys, and this is going to lower our blood volume and our pressure. It will respond to stretching of heart walls, reduces our thirst, it blocks the release of ADH and aldosterone, and it can cause diuresis. It lowers our blood pressure and our plasma volume. These hormones are natural antagonists to the renin, angiotensin, aldosterone system, or the RAS system. The restoration of lower arterial pressures will inhibit further release of ANP and BNP. We have to look at the alterations in sodium water very closely. They're very closely related. If there's a water imbalance, this can be maybe from changes in the osmotic gradients, and it can be caused by either too much salt or we lost too much salt. So we're gaining or we're losing salt. So sodium imbalances can also occur when we lose too much water volume. Alterations are generally going to be classified as changes in our tonicity. And the change in the concentration of our electrolytes in relationship to the water is tonicity. So it's either isotonic, hypertonic, or hypotonic. Changes in tonicity are going to alter the volume of water in the intracellular and the extracellular compartments. And this is going to result in either hypovolemia, euvolemia, so nothing changes, it's okay, or hypervolemia. So let's first look at isotonic alterations. So this middle one here. Isotonic alterations, everything is good. It's compatible with our normal fluid in our body, because that's something to remember. So these are the most common, and they occur when there's changes in total body water that are accompanied by proportional changes in the electrolyte concentrations. Isotonic fluid loss causes dehydration and hypovolemia. So let me give you an example. If you lose pure plasma or extracellular fluid, your overall fluid volume is going to be depleted. Therefore, your electrolytes will also be depleted, and your osmolality, though, is going to remain normal. Changes to our tonicity here can be caused through hemorrhaging, severe wound drainage. Maybe you have excessive diaphoresis or sweating. There can be a loss of extracellular volume. Also with weight loss, if you have very dry skin or dry mucous membranes, decreased urine output, you might see increased hematocrit value and see symptoms of hypovolemia. These are going to tell you that you have a patient in the state of hypovolemia. Rapid heart rate, maybe their neck veins are very flat. You can see it in terms of lower blood pressure, but also normal blood pressure as well, as there's compensation. But in severe hypovolemic shock or severe hypotension, this can also occur. The isotonic fluids that contain electrolytes and glucose are then going to be given orally or, in severe cases, intravenously. So what are those isotonic alterations or fluids that can fix isotonic alterations? Normal saline, so that 0.9% saline, 5% dextrose can also be commonly used. Now we're going to look at hypertonic alterations on this side. So water goes out of the cells and they cause the cells to shrink. So hypotonic fluid alterations, this is going to develop when the osmolality of the ECF is higher than normal. The most common cause is an increase in concentration of the ECF sodium, or if we have hypernatremia, or if there's a deficit in the free water in the ECF, or both. In any instance, the hypertonicity of the ECF is going to attract water from the intracellular space, so then it causes dehydration in the cells. So water goes out of the cells, causing them to shrink. The primary increase in the amount of ECF sodium causes this osmotic attraction of water, and then we have symptoms of hypovolemia. In contrast, though, a hypertonic state can be caused by free water loss that leads to hypovolemia. Now we're going to look at hypotonic alterations. This is when water goes into the cells and it's going to swell up. So it's the opposite of the hypertonic alteration. So with hypotonic fluid alterations, this is when the osmolality in the ECF is less than normal. And the most common cause is hyponatremia, not having enough sodium, or if there's an excess in free water. For instance, when our body is intoxicated with water. Both of these things can lead to intracellular overhydration. So you can see the cells actually become edematous. The water is moving into the cell because the osmotic pressure is greater. When would this happen? If we had cerebral and pulmonary edema in conjunction with fluid shifts, if we have hyponatremia and that plasma volume is decreased, this is going to lead to symptoms of hypovolemia. If we have free water excess, the ECF fluid is going to elevate and it's going to cause symptoms of hypervolemia. And you can use this table here to truncate the explanation of the mechanism of the tonicity states. We're going to look at dehydration, overhydration, and dilutional hypotonic hyponatremia, otherwise known as water intoxication, and the causes of each. So for dehydration or water depletion, this can occur because of excessive perspiration, inadequate consumption of water. If we have a patient that is repeatedly vomiting or having diarrhea, or has a fever and hypoventilation is occurring as well. Also, patients with burns could also have dehydration. Someone with overhydration, this is someone who's drinking too much water, the consumption of water, or they're given hypotonic solutions, or they have an endocrine disorder such as excessive ADH production, or the inability to eliminate excess water in urine. So someone that has renal failure, heart failure, or cirrhosis. In water intoxication, this is someone who is excessively sweating. For instance, maybe an endurance athlete, and so they're sweating for long amounts of time. It stimulates their thirst and the intake of large amounts of free water. Someone with a psychogenic disorder could have compulsive water drinking. Someone who takes SSRIs, or they have SIADH, which is the syndrome of inappropriate antidiuretic hormone. Now we're going to talk about the relationship between our extracellular fluid and our blood pressure. So what happens if our extracellular fluid is too excessive? Well, the natriuretic peptides will kick in, which is going to reduce our thirst. This is going to then block ADH and aldosterone. And if this happens, then salt and water loss in our kidney is going to increase, therefore decreasing our extracellular fluid. So when ECF rises, blood volume goes up and blood pressure rises. But what happens if our ECF volumes are inadequate? Well, then our blood pressure is going to decrease because the RAS system is getting kicked in, therefore triggering water and sodium losses to be reduced, and our extracellular fluid will rise. So when our ECF drops, our blood volume goes down and our blood pressure decreases. First, with our electrolyte imbalances, we're going to look at too much sodium or hypernatremia. And this can be caused by an acute increase in sodium level or a acute loss of water. So the first one, isovolemic hypernatremia, this is the most common. This is when you lose water and normal body sodium concentration still occurs. This is dehydration. Hypernatremia, when we have lots of water deficit manifested by ICF and ECF hydration and volume depletion, this can also cause dehydration, and we're going to see weight loss, weak pulses, low blood pressure. It can also manifest as patients becoming very thirsty. They have a headache, dry skin, and dry mucous membranes. Their temp may be elevated and their urine may be concentrated. However, hypernatremia because of excessive sodium intake or a decrease in sodium loss in relationship to water, this can cause a hypertonic state in our ECF. So we have hypervolemia and ICF dehydration. So we might see thirst, however, we're going to see water gain. Our pulses in this case are going to be bounding and our blood pressure will be increased. We might see alterations in our membrane potentials and also our brain cells start to shrink. We're going to see muscle twitching, hyperreflexia, confusion, coma, seizures, irritability, and possibly even cerebral hemorrhage. In hypovolemia, the loss of sodium but greater loss of water in a hypovolemic hypernatremia. This can be caused if we give patients diuretics and they're losing lots of water, but they're not losing the same amount of sodium, or if their kidneys are not diluting their urine. And remember that hyperchloremia, or too much chloride, is caused by an excess of sodium, because whatever sodium does, chloride is doing passively. And it has an inverse relationship to bicarb. So if there's too much chloride or hyperchloremia, then there's going to be a deficit in bicarbonate. So then on the other hand, if we have not enough sodium or hyponatremia, this is usually because of the movement of water in the cells when we are hydrating too much. So think about an athlete, a marathon runner that is excessively sweating, therefore triggering that thirst response and drinking, but removing all that water in the cells. What's going to happen is that our sodium gets depleted, therefore, in relationship to the water. And therefore, when you are running a marathon, in addition to having water at water stations, there's also salt packets to help replenish that salt. And hyponatremia can also be caused by sodium loss or not enough sodium intake or dilution of your body's sodium level, again with excess water. What will happen is the cells or the water will move into the cells and it can rupture the membranes. In isovolemic hyponatremia, the sodium deficit is occurring, but there's no water loss. This can happen with syndrome of inappropriate ADH. We have water retention. In hypervolemic hyponatremia, this is when sodium is going to increase, but water also increases. And so the dilution of sodium is occurring in the ECF. This happens with heart failure, cirrhosis, edema. In hypovolemic hyponatremia, this is when you are losing water, but there's a greater loss of sodium. Your ECF is going to decrease. This happens with vomiting, diarrhea, use of diuretics, or if there is an adrenal insufficiency causing low aldosterone. Your neuron's ability to depolarize and repolarize is going to be altered with hyponatremia. And what you would see in your patients is lethargy, confusion, apprehension. Their reflexes may be decreased. It may put your patient into a coma, seizures. You might even see muscle twitching and weakness, which are also common with hyponatremia. And hypochloremia, remember, it follows sodium, so we'll also see hyponatremia, or inversely, elevated bicarb concentrations. And this is usually the result of excessive vomiting or a loss of hydrochloride. It occurs with patients that have cystic fibrosis. And also, the treatment for this is just trying to treat the underlying cause. In addition to sodium and chloride, we're going to now look at alterations in potassium, calcium, phosphate, and magnesium balance as well. And I saw this clipping in your book I thought it was interesting, and it had to do with potassium, hypertension, and stroke. And it said that the enriched dietary intake of potassium is associated with lower risk of hypertension and stroke. And the American diet often exceeds the recommendation for sodium, but not potassium. We actually have a deficiency there. So there has been found a correlation with if the more potassium you have, the better outcome you may have in reduction in heart disease. So, increased high risk of blood pressure, cardiovascular disease, mortality when the plasma ratio of sodium concentration to the potassium concentration was high. So, we're going to look at potassium first. Potassium is an intracellular cation. So potassium is primarily in the ICF. The potassium is higher inside the cell, where sodium is higher outside of the cell. And this is where we have the sodium-potassium pump. We have 2 potassiums for every 3 sodiums that go out. So 2 potassiums in and 3 sodiums go out. The potassium balance is regulated by our aldosterone and our insulin secretions, and it changes in our pH. So the balance of the rate of the gain of potassium across our digestive epithelium and the rate loss into our urine. Now let's think about in terms of diabetes. So with insulin deficiency, insulin is going to activate sodium-potassium pump, but the potassium is just going to sit in the blood if we don't have enough insulin to do its job. In acidosis, it's going to move hydrogen ions into the cell. It's going to move potassium out of the cell. And this is going to fix acidosis. With nephron filtration, with acute kidney injury, you're going to have a person with low GFR, glomerular filtration rate. This is going to lead to oliguria, or little to no urine. Therefore, we're going to see an elevation in potassium. So why is potassium so important? Well, it helps to transmit nerve impulses. It maintains the resting potential. It's going to regulate our intracellular osmolality, acid-base balance, as you can see previously. And it's required for the deposition of glycogen in the liver and our skeletal muscles. Our myocardial, skeletal, and smooth muscle contractility is also a function of our potassium. I want you to note that there's 3 electrolytes in which correct concentration is going to be the most critical. Otherwise, you're going to see some type of heart function abnormality. You always have to have potassium, calcium, and magnesiums at the correct level to decrease the risk of arrhythmias or other complications in your heart. In terms of diffusion and active transport against the cell membrane, this is going to help with potassium balance. So the potassium is going to leave the cell by diffusion, which is moving to a lesser concentration, but then moved back into the cell by active transport. The major controller of our potassium is our kidneys. The kidneys are going to help reabsorb potassium by the proximal tubules and then secrete it in the distal tubules. When we have renal failure and we don't have this process complete, we can have hyperkalemia. In healthy individuals, our kidneys are going to respond to too much sodium by flushing it out in the urine. But unfortunately, when we do this, it also removes potassium. And if our potassium levels are too low, the body tries to hoard onto it. And this also means that it's going to hoard sodium. Because water follows sodium, this is also going to have your body hoard water. We have too much water. And therefore, we're going to have too much volume in the blood circulation, which equals an increase in blood pressure. Our heart has to work harder. And this excessive sodium is going to blunt the ability for our blood vessels to relax and contract with the ease that it should. So then our heart gets overstimulated and the heart tissue grows. This can all be a response with low potassium. Both insulin and the catecholamines, like epinephrine, can increase our cells' ability to uptake potassium by increasing our potassium sodium pump. Epinephrine is going to facilitate that movement of potassium into the muscle tissue during periods of physiological stress. Insulin can also do the same thing. So you could see that insulin promotes the movement of potassium back into the cell. We'll give me an example. When potassium is very high, if you give patient insulin and glucose, this is going to move the potassium back into the cell and out of the intravascular space. This is only going to buy us a little bit of time. We have to find a long-term solution, but it's a good quick solution. Epinephrine is going to help move potassium back into the tissues. But also with low magnesium levels, this can contribute to the urinary potassium losses. So low potassium and low mag, they exist together. They follow one another. And so you can't correct the potassium unless you're correcting the magnesium as well. So a lot of the times when you have a patient with low potassium, you're also going to replace mag or magnesium also. Going back, I think I skipped a couple. Acid-base balance. With the acidosis, we've talked about this in another slide. It's going to move that hydrogen ion into the cell, and then potassium is going to be pushed out. Diuretics, they can increase potassium loss as well in the distal convoluted tubules because you are diuresing water, potassium follows, and sodium will follow as well, unless you give a potassium-sparing diuretic. And then you can also lose potassium with vomiting and gastric suctioning. This can also remove potassium too. Hyperkalemia, so increase of potassium intake. This can happen when there's a shift of potassium from the ICF and it's moving to the ECF. Or it could be because we have decreased renal excretion, so with renal failure. Hyperkalemia can lead to ventricular arrhythmias, muscle weakness, or paralysis. We talked about hypokalemia quite a bit, and this is the shift from the ECF to the ICF, and we lose total body potassium. This can happen when we have increased aldosterone, which is going to increase our renal secretion of potassium. Respiratory alkalosis or diabetes ketoacidosis can also cause hypokalemia as well. Diabetes ketoacidosis is when our blood sugar becomes extremely high, and then we have Kussmaul respirations trying to blow off that acid. And so you might see that in a patient with diabetes ketoacidosis. With hypokalemia, this can cause metabolic dysfunction, muscle weakness, atony, and cardiac dysrhythmias. So I wanted you to see some EKG effects of hypokalemia. Sometimes it can cause the presence of U waves, which you can see here, which are not normally there. It can also cause the widening of the here's the U waves. The QRS complex becomes very wide, as you can see here, with hyperkalemia. It can also cause sinus brady, AV block, and paroxysmal tachycardia. So what statement is true regarding potassium? Potassium is a major extracellular electrolyte, or is it during acidosis potassium shifts into the cell, or aldosterone is secreted when potassium is decreased, or insulin causes the movement of potassium into the cell? The answer is D. Insulin is going to move potassium back into the cell, and it's a treatment of hyperkalemia. There's too much potassium in the blood serum. That's why when we get the lab through blood work, we're seeing high potassium levels. What we want to do is move that potassium back into the cell, and we can do that by giving insulin. Let's look at A, B, and C now. Potassium is the major intracellular electrolyte, and it's what helps to maintain that osmotic balance in the intracellular space, or the ICF. During acidosis, potassium shifts out of the cell in exchange for hydrogen ions, and aldosterone is secreted when potassium is elevated, resulting in the excretion of potassium by the kidneys. We're going to move on to calcium and phosphate and their relationship. Calcium is found in the bone. 99% of it is found in the bone, and calcium is a necessary ion for metabolic processes. It's the major cation that provides the structure for our bones and our teeth, and it's an enzymatic cofactor for the clotting cascade and our ability to clot. Hormone secretion and the function of cell receptors is also dependent on calcium, and also the plasma membrane stability. Its permeability and ability to repair is also going to be based on calcium. Calcium is also important for the transmission of our nerve impulses and the contraction of our muscles. Phosphate is located also in our bones. 85% of phosphate is located in the bones, and it is a buffer and acid-base regulation in both the ICF and ECF. And if you can think about ATP found in the ICF. Phosphate also provides muscle contraction ability and also provides energy. There are three things that influence the calcium and the phosphate balance concentrations. These are the parathyroid hormone, vitamin D, and calcitonin. And we're going to go ahead and look at the parathyroid hormone. We're going to look to see how the parathyroid hormone influences the balance of calcium and phosphate. So an increase in calcium in the ECF can be because of a few things. It can be that there is more absorption in the kidneys of calcium, or that there's reabsorption of the bone of calcium, or we have lower phosphate levels because our urine is excreting phosphate or too much phosphate. So remembering that calcium and phosphate have an inverse relationship. If there's too much of one, there is lower amounts of the other, and vice versa. So the parathyroid hormone is going to stimulate the release of calcium from the bone by stimulating bone reabsorption. It can decrease our urinary loss of calcium by stimulating calcium reabsorption. And it can indirectly stimulate calcium absorption in the small intestines by stimulating the synthesis of vitamin D125 in the kidneys. So we're going to take a look at this conversion here. So vitamin D, a fat-soluble steroid ingested in our food, or it's synthesized in our skin when we have UV lights. We need it. But there are several steps in order to actually activate vitamin D before it can go into the target tissues. And that first step happens at the liver. But the final activation is actually here in the kidneys. The renal activation of vitamin D begins when serum calcium levels decrease, and it's going to stimulate the parathyroid hormone. Once that parathyroid hormone acts to increase calcium reabsorption, it enhances the renal excretion of phosphate. It's going to produce then decreased phosphate as our calcium levels are increased. That combination of low calcium level and increased pituitary hormone causes this renal activation of vitamin D. Once this activated vitamin D circulates in the plasma, it acts as a hormone that increases the absorption of calcium and phosphate in the small intestines. It's going to enhance bone calcification, increase the renal tubular reabsorption of calcium, and therefore it's going to increase the excretion of phosphate in our urine. However, when renal failure occurs, vitamin D can't be activated. And therefore, serum calcium levels decrease and phosphate levels increase. So you would see higher phosphate levels in a patient with renal failure. However, as calcium levels increase, the opposite is going to happen. This is going to lead to the suppression of PTH and therefore decreases vitamin D activation. It's going to increase calcium reabsorption or absorption, and then it's going to increase the renal phosphate reabsorption. So again, calcium and phosphate, they're inversely proportional. They are very tightly controlled. Calcium and phosphate will move in opposite directions. When one goes up, the other one will go down. If phosphate increases, calcium absorption from the gut will then decrease. Our serum calcium should be in the range of 8.5 to 10.5 milligrams per deciliter. Serum ionized calcium is 4.5 to 6 milligrams per deciliter. The ionized calcium is what can be used by the body. Remembering that the absorption happens in the digestive tract and then reabsorbed in the distal convoluting tubules. When there's a loss, it occurs in the bile, the urine, or the feces. Serum phosphorus, the levels are 2.5 to 4.5 milligrams per deciliter. Now we're going to look more specifically what happens to our body if there is high calcium or low calcium. So we'll start with the high calcium. And think about what you would see in your patient if they were diagnosed with high calcium. You would see fatigue, weakness, lethargy, anorexia, nausea, constipation. There may be impaired renal function. It may cause calcium kidney stones. Dysrhythmias, what you would see narrow T waves. It can cause bradycardia, cardiac arrest, bone pain, and even osteoporosis. But what causes these symptoms in the first place? What causes hypercalcemia? Anything over 10.5 milligrams per deciliter. Hyperparathyroidism, which would cause an oversecretion of PTH. If there is metastasis in the bone, this is going to alter calcium resorption. Often breast, prostate, renal, and cervical cancers can do this. If you have a tumor that produces more PTH, or if you're taking too much vitamin D or calcium supplementation. So you can see all that here in hypercalcemia and compare it to hypocalcemia, which we're going to look at next. In hypocalcemia, anything under 9.0 milligrams per deciliter. If you were working with the patient, you might see increased neuromuscular excitability. They might say they have some tingling. Muscle spasms, even intestinal spasms can occur. Seizures, and even tetany in some very severe cases. You might see prolonged QT intervals that can cause cardiac arrest, increased risk of bleeding. And there's two things that we can do as far as our health assessment to see if maybe a patient has hypocalcemia. The first one is Chopstick sign. And what you would do with Chopstick sign is you would actually elicit by tapping on the facial nerve just below the temple. A positive sign would be if the nose or the lip starts to twitch. This could tell us that they are hypocalcemic. Trousseau sign is the contraction of the hand and the fingers when you have an occlusion of arterial blood flow for 5 minutes with the use of a blood pressure cuff. And you can see in relationship between the hypocalcemia and the hypercalcemia. The cause here now is renal failure. Inadequate intestinal absorption. Blood administration could cause it. Too much citrate. Pancreatitis because of the malabsorption of fat. Decreased parathyroid hormone and vitamin D. Nutritional deficiencies can occur with inadequate intake of dietary green leafy vegetables or dairy products. Now we're going to move on to high and low levels of phosphate. So again, remembering that about 80% of phosphate is located in the bone, and it is required for bone mineralization. It's necessary for the formation of ATP and DNA, and it is involved in our acid-base balance, cellular immunity, and also bone strength. We absorb phosphorus in the GI tract under the control of vitamin D, which we saw in the PTH feedback loop. Reabsorption of phosphorus also takes place along the proximal convoluting tubules. A patient with mild to moderate kidney dysfunction would have elevated levels of phosphorus, and conversely, they would have low levels of calcium because if one goes up, the other one goes down. Now, phosphate is often referred to as phosphorus, and this is why it's in parentheses. It's a practice that is inaccurate and kind of misleading because elemental phosphorus is only present as part of an organic and inorganic compound. It's not present as the free form in the human body. So really, we should be calling it phosphate. With hyperphosphatemia, anything over 4.7, we might see prolonged calcification of soft tissues in the lungs, kidneys, or joints, which means that there's low calcium, because if there's too much phosphate, there's low calcium. We might see this with acute or chronic renal failure or insufficiency. We might see this if phosphate is released due to chemotherapy for metastatic tumors, or if we have hypoparathyroidism. So most of our phosphate is actually located in the cells, and the cell destruction associated with the metastatic tumors with chemo can release these large amounts of phosphate into the ECF. Also, it's not listed here, but if you use phosphate-containing enemas or laxatives long-term, this can also lead to too much phosphate. Well, what causes too little phosphate, under 2.0? If you have the malabsorption due to vitamin D deficiency, as we saw in the PTH feedback loop, or if someone is ingesting too much magnesium containing acids or aluminum containing antacids. This excessive use of magnesium containing and aluminum containing antacids leads to hypophosphatemia, and these patients might be someone that has GERD and they're just kind of treating their pyrosis over the counter. They don't realize that these Tums and other antacids have a lot of magnesium in it, and because of the relationship that it has on phosphate, they don't realize that they're causing their phosphate levels to become lower. Primary hyperparathyroidism redistributes the phosphate in the intracellular compartment in response to respiratory alkalosis. This can also cause low phosphate. What you would see with your patient is irritability, confusion, numbness, coma, convulsions, reduced capacity for oxygen transport by red blood cells, and disturbed energy metabolism. You might see with patients with hypophosphatemia, low leukocyte and platelets and lower function of these leukocytes and platelets. It can also cause deranged nerve and muscle function, and therefore, if it is occurring in our lungs and thoracic area, it can cause respiratory failure. Magnesium is an intracellular cation. It's second to potassium. Only about 60% is stored in the muscle and bone, and 30% is actually in the cells. Again, another important structural component of the bone, and very important in our heart function, along with our calcium and our potassium. It is being actively reabsorbed by the proximal convoluted tubules, and the dietary magnesium is being reabsorbed there to balance our urine loss. Regulation overall of our magnesium metabolism is balanced by the small intestines and the kidney. When we have low serum levels, this can cause renal conservation of magnesium. It's trying to hold on to it. But we need magnesium. It's a cofactor in intracellular enzymatic reactions, protein synthesis, and even nucleic acid stability. It also is a factor in neuromuscular excitability. So therefore, when you see a patient with too much mag or not enough mag, you might see disruptions in these processes. So if you have too much magnesium, that's 3.0 milliequivalents per liter, it is pretty rare, but it's usually caused by renal failure. We also see it again, we talked about this with magnesium containing antacids. They can potentiate excess magnesium levels, or if we have excess magnesium concentrations, depressing our skeletal muscle contractions and our nerve functions. So the signs and symptoms that we're going to see are nausea, vomiting, muscle weakness, hypotension, bradycardia, respiratory depression. And what we would need to do is make sure that we are avoiding magnesium containing substances. And if this patient was in renal failure, which is the usual cause, then we have to make sure that during dialysis that we're removing the magnesium levels. And this is why it's so important to get electrolytes before any type of dialysis. In hypomagnesemia, this is anything under 1.5 milliequivalents per liter. What would we see here? we would see behavioral changes, irritability and depression, increased reflexes, muscle cramps, muscle weakness, even ataxia. We might see nystagmus of the eyes, tetany, convulsions, tachycardia, and hypotension. But what causes hypomagnesemia? It can be caused by not enough magnesium in our diet, so malnutrition, or if we have malabsorption syndromes of the GI. Alcoholism can also cause low magnesium, and if there's urinary losses from the renal tubular dysfunction. Loop diuretics like Lasix can also lower magnesium, and it can lead to then refractory lower potassium because they too move together. Which is initial treatment of hypernatremia? So first, let's recall what hypernatremia means. And hypernatremia can occur when our sodium levels exceed the range. And when we have increased serum sodium, it can be caused by maybe an acute gain in our sodium or a net loss of water. And because sodium is largely found in the extracellular fluid, the sodium gains can cause intracellular dehydration. So the treatment for hypernatremia is to give an isotonic, salt-free fluid, right? Because we have too much sodium, hypernatremic. So this is usually like a 5% dextrose in water. And we're going to give it until the serum sodium level returns to normal. We have to give an isotonic salt-free fluid. Restricting the fluids of a diuretic, restricting the fluids or giving a diuretic, these are used for edema, which we can see with hypernatremia, but first we have to stabilize the sodium level. And that's why we're going to use the isotonic salt-free. We wouldn't give normal saline because it has saline. And this would only be used to treat an isotonic type of fluid loss. The answer here is